So, good evening, everybody. It's indeed my pleasure to welcome you all to this webinar hosted by NephroPlus. And it gives me great pleasure to introduce the speaker for today evening's talk, Dr. Sampathkumar, a senior colleague of mine and also a mentor for me for my career at various time points. Sampath, for those of you who may not know him, which is going to be a very small number, is what I would call as a trailblazing nephrologist stationed at Madurai, practicing at Madurai Meenakshi Hospital as a senior nephrologist. The reason why I use the term trailblazing is Sampath is somebody who's excelled across three arms as a very popular and a competent clinical practitioner. Secondly, as a trainer and an educator running the DNB program there, out of it we've had some excellent nephrologists graduate out of. And thirdly is his research. And Sampath has this very unique way of looking at very decisively and intuitively. And he's brought out some very fantastic small RCTs, which many of us wouldn't think of. And to his credit, he has held several positions within the nephrology fraternity. He was past secretary of the ISN Southern chapter in 2000, in the mid 2000s, of which I followed after him. I learned a lot from him at that time. He was also past secretary of the Peritoneal Dialysis Society of India. He's presently the president-elect of the Asia Pacific Society of Dialysis Access. He is an examiner for the DNB and also for the MRCP cases exam. He's on the editorial board of Indian Journal of Peritoneal Dialysis and Open Journal of Urology and Nephrology. Sampath is extensively published and he's a reviewer for several national and international journals. Sampath is going to share his knowledge on what in nephrology we call as HIF inhibitors, which is changing the landscape of renal anemia management. Sampath mentioned in the conversation before this webinar, he's broadened the talk to more recent concepts in renal anemia. Over to Sampath, it's a pleasure to welcome you, and I'm sure all of you will have a richly educational hour.
Thank you.
Thank you.
Thank you, Suresh. You have been a very close friend of mine for many years, and I'm sure that has possibly taken you to give me so much flattery. Thank you. So let me share my slides. Is it okay now? Not at full screen. Is it okay?
Yeah, doctor, we can see your screen.
Yeah, doctor. Thank you, NephroPlus, for this great opportunity. And I know that I am addressing a mixed audience consisting of both nephrologists and also dialysis technicians and dialysis sisters. So let me take you through what we have really achieved as nephrologists in the management of renal anemia. And then I'll talk to you about the recent advances in this field. So way back in the 19th century, this was observed that the most remarkable character of the blood in the advanced stages of Bright's disease, the so-called Bright's disease in those ages, is a rapid reduction of its coloring, meaning that there is a development of anemia in patients who have renal disease. So this was observed very long back. And anemia is an extremely common side effect of chronic kidney disease, so much so that in sitting in a busy OP, in the medicine OP, if somebody has both anemia and his raised blood pressure, immediately our thoughts go to diagnosis of chronic kidney disease. So this combination of hypertension, anemia, and pedal edema takes us to the diagnosis of chronic kidney disease. And in patients whom all of you are caring for, patients who have estimated GFR of close to 5 or 6 ml per minute, meaning that they are in advanced stages of chronic kidney disease, anemia is almost universal. So more than 80 to 90% of people have anemia. So much so that if somebody does not have anemia, then we start thinking, are there any other diseases that this patient has, like polycystic kidney disease, etc. And is anemia merely a side effect of chronic kidney disease, or does it contribute to mortality? So initially we were thinking that anemia control, or if you improve the anemia and if you improve the hemoglobin concentration in a patient with chronic kidney disease, you make them feel better, you make them exercise better, and the quality of life improves, their appetite improves, etc. But does it have any survival advantage? So this CRIC study, where people are being monitored across the continuum of more than a few decades, it has been shown that the people who have untreated anemia have an increased risk of death and also end-stage renal disease. So both these are very, very important causes, important reasons why anemia should be managed properly. And if you remember your hematology, you will find that the RBCs are produced from the pluripotent stem cells onto the BFUs and CFUs. And this is where this erythropoietin is acting to increase the number of these cells so that they don't undergo apoptosis. And so you have the pro-erythroblasts are developed in large numbers, and the heme is incorporated, and iron is incorporated into the hemoglobin, and reticulocyte production is starting, and you have the RBCs. So patients who have progression of renal disease develop anemia due to many reasons. One of the common reasons that everybody knows is that there is a decreased erythropoietin production. This erythropoietin is produced from the interstitial cells of the kidney. You may ask people, non-nephrologists and non-doctors will ask, what is the connection between erythropoietin and kidney? Why should erythropoietin be generated from kidney to increase the oxygen capacity, oxygen carrying capacity of the blood? This is where nature's inscrutable ways come in. And not in the lungs, not in the respiratory system, the erythropoietin is produced, but it is produced mainly in the kidneys because of the fact that the kidney acts as a crit meter. By crit meter, I mean that the kidney very, very carefully titrates the amount of cells in the proportion of cells in the blood versus proportion of plasma. So when the proportion of cells increase dramatically, then the blood cannot traverse through small capillaries. On the other hand, when the fluid phase of the blood increases, then the oxygen cannot reach the tissues because the oxygen is taken mainly from, carried mainly through the RBCs. So you need to have a balance of the cells as well as the plasma. And this hematocrit that we call is very carefully maintained with the help of the renal tubular cells, and especially at the ascending and the descending loops of Henle. And this is where precisely where the cells which are producing erythropoietin are present. The second aspect, as we have already seen, is that you need, even when there is erythropoietin presence, you need iron. So if somebody has iron deficiency, then it is impossible to produce RBCs in large numbers. You also have other reasons why people on dialysis lose RBCs and lose blood, because every time the dialysis nurse connects the patient with a dialysis AV fistula needle and disconnects it, there is definitely going to be blood loss. And people who are on dialysis have very poor appetite. So poor nutrition also contributes to the low iron stores. And they are again prone for infection and inflammation. So there are many, many reasons why anemia sets in patients with chronic kidney disease, and also especially on dialysis. And the treatment that we have been providing them over the last 30 years, like earlier, pockets and pockets of blood transfusion used to be given. So blood transfusion was the common go-to management tool that we had 30 years ago. But the problem with blood transfusion, as you all know, is that there is an increase in the chances of infections like hepatitis B, HIV, etc., and also iron overload. So blood, and also when you are thinking in terms of doing a renal transplants for them, these people become sensitized so that their antibody levels go up and they are at a higher risk of rejection. Then we started with oral iron, and oral iron is easy to administer, relatively inexpensive. But the problem with oral iron is that the iron absorption in patients who are on dialysis is not so good, and they also produce a lot of nausea, vomiting, etc., not very well tolerated. Even though new formulations like liposomal iron has come in, we are not very enthusiastic about using oral iron for our patients who are on dialysis. Then comes intravenous iron. So when we were house surgeons, we used to use intravenous iron mainly in the gynecology and the obstetric wards. But now nephrologists are the main users of intravenous iron. Now cardiologists are catching up. So intravenous iron is a very good method of starting somebody on the management of anemia, because more than 50 to 70% of our patients are iron deficient. So if you are going to start them on erythropoietin before you give them iron or replenished iron stores, then the erythropoietin is not going to be very effective. So that is why we always go along with erythropoietin and iron therapy. Then we come to erythropoietin therapy, which is one of the greatest advances in the modern medicine. The bioengineered erythropoietin can be administered both intravenously or subcutaneously. Most often in the dialysis room, it is given as an intravenous push at the end of dialysis. Or if somebody has outpatient management of anemia, they can be given subcutaneously. Earlier, we had the original molecule of synthetic erythropoietin. Now we have additions of the bioengineered molecules with darbepoetin and the sera, the continuous erythropoietin stimulating agents. So these can be given as once a week or once in 2 weeks. So these are the therapies that we have been routinely providing for our patients. But why should we need a new drug beyond erythropoietin? The problem with erythropoietin as a therapeutic choice is that it is easy to overshoot the mark and go to higher levels of hemoglobin, higher levels of hematocrit, which has its own problem of increased cardiovascular risk. This has been repeatedly proven by multiple studies in the last 20 years that if you increase it beyond a hemoglobin of 13 or 14, you are not providing them benefit, but on the other hand, there is increased risk of both stroke as well as increased myocardial infarction and cardiovascular events. The reasons are not far to seek, is because when you give erythropoietin in increased doses in those who have erythropoietin resistance, what happens is this erythropoietin can sit on the other receptors. It can sit on the platelet increasing receptors, and this can increase the platelet adhesiveness into the endothelium and increase the risk of stroke. So there is always space for newer agents, and this is where these hypoxia regulatory systems come in to our focus in nephrology. So when we talk about these hypoxia-inducible factors, we'll take a leaf out of Hinduism and say that oxygen is a true trinity of life. We are born of oxygen, the Brahma, and we live by oxygen, the Vishnu, and we die by oxygen, the Shiva. The reason why we die by oxygen is that the oxidative damage which happens in patients as we get older is the cause of senescence and death. And oxygen is the ultimate electron acceptor in the process of oxidative phosphorylation, which generates the ATP. And this is the real petrol for our energy in our day-to-day activities. And we live by ATP from the catabolism of glucose and fatty acids. And these hypoxia-inducible factors, they regulate the supply and demand. They match the supply and demand. So we'll see how. And the research into the hypoxia-inducible factors has started way back in the 1890s, when people have researched as to how when the oxygen levels are very low in the mountains, how people are existing and people are able to live. And these pioneering experiments in the Italian Alps and also the Yale expedition in the Pikes Peak in Colorado also gave us the inkling of how body adapts to low oxygen levels by increasing the hypoxia-inducible factors, which ultimately increases the erythropoietin levels. So here we are going one step forward from merely giving erythropoietin to stimulating the endogenous erythropoietin levels in our body. This is where these molecules come in. And when somebody has normal oxygen levels, as all of us are sitting and listening to the lecture, what happens is the hypoxia-inducible factors, they always operate in dimeric form. They operate like phospholus who operate in tandem. So HIF alpha and HIF beta have to be operative in tandem to produce erythropoietin levels. But normally, when oxygen levels are present in excess, as we all have, then these prolyl hydroxylase enzymes, these prolyl hydroxylase domain proteins are nothing but proteins which are available in the cellular cytoplasm. They tend to inhibit or reduce the effectiveness of HIF alpha by hydroxylation and acetylation. See, these are chemical reactions which are happening every moment in our body so that there is no excess stimulation of erythropoietin. And this HIF alpha, once it is hydroxylated and acetylated, are taken by another protein called von Hippel-Lindau protein, VHL protein, to the cleaners. So this is the so-called shredder machine that all of us have in our cells. You would have seen in offices the shredder machines which shred the papers. In the same way, HIF alpha is being shredded by this ubiquitin system, proteasome system. There is continuous shredding and degradation of this HIF alpha system. So what happens when somebody has low oxygen? So he is climbing Mount Everest or he is going to Rishikesh. Then what happens? Then this hypoxia-inducible factors, HIF alpha, the prolyl hydroxylase is inhibited and the HIF alpha is translocated to the nucleus. And in the nucleus, it combines with his other cofactor, the HIF beta. So this HIF alpha and HIF beta have to combine together and they go and generate the hypoxia responsible genes, which ultimately result in the erythropoietin generation. So EPO genes are stimulated to produce erythropoietin. So this is a system which is going on every minute in our body. And this is the overall system that I have taken you through the pathway. So when there is hypoxia, there is HIF1 alpha and HIF1 beta, and there is hypoxia-inducible factors, target genes, and this gives rise to increasing erythropoietin generation and also increasing angiogenesis, by which we mean that increased production of the arteries and the vascularity increases, and also some what is seen here as, which is not very welcome, issues like invasion and metastasis of cells which are malignant. There is a group of patients who are a group of population in the central Russia, again gave us a very interesting insight into how these hypoxia-inducible factors are generated. These Shuas people have a mutation in the VHL protein. So they have increasing incidence of polycythemia. So this again gave us the information about how the hypoxia-inducible factors produce increase in the hemoglobin. The other reason that I told you about this hepcidin pathway, and this hepcidin pathway, the iron, which is very important for the incorporation into the RBCs. the dietary iron is usually sufficient to replace most of the daily losses. But what happens in patients with chronic kidney disease is that there is a shut-off of the iron stores from getting into the mainstream, into the plasma, to get incorporated into the RBCs. So this is because of the presence of inflammation. So inflammation increases the production of this hepcidin, which is again a protein, from the liver, so that the body thinks that when there is inflammation, there is a lot of infection. So let us not give iron to the microbes, because as we know, bacteria thrive on iron. So the body thinks that there is inflammation. So let me overproduce, or let me secrete hepcidin from the liver. Let me shut off iron from all the stores, so that iron is not available for the microbes. But what happens in the patients with chronic kidney disease is that these patients have very poor iron levels, and this produces iron deficient RBC production. So we have large enough HIF stabilizers, and the roxadustat, vadadustat, daprodustat, molidustat, and desidustat. What is very heartwarming for an Indian is that this molecule, the desidustat molecule, is really a desi molecule. In fact, it is formulated by an Indian company, the Zydus, and this has got the approval of FDA, and all over the world it is being now taken up in Japan and in other countries. So we are now going into the stage where the molecule is going to knock at the doors of a variety of international bodies. Desidustat has a minimal chances of drug-to-drug interaction, since it is not metabolized by the traditional cytochrome P450 enzymes in the liver. And the different HIF fees, the prolyl hydroxylase inhibitors, have slightly different pharmacokinetic properties. The absorption and the dosing are all slightly different. But what we know and what we have been using is that this desidustat, we are using 100 milligrams twice weekly. And this dose has been found to be very, very good in our patients to improve the hemoglobin levels. And the evidence of desidustat is brought about by two studies, the DREAM-ND study and the DREAM-D study. The DREAM-ND study is from non-dialysis population, where more than 500 patients were enrolled on an 1:1 basis, receiving desidustat and darbepoetin. And the result has been shown to be non-inferior. The time to achieve the target hemoglobin and the percentage of hemoglobin responders were equivalent. And they have now noted that there are some advantages, that there is some slight reduction in the LDL levels in patients who are given desidustat. And there was also a welcome reduction in the hepcidin levels, which, as you know, can improve the iron mobilization from the spleen and the other reticuloendothelial cells, so that iron can be mobilized for RBC production. The serious adverse events were not different. So again, giving us the confidence that this drug can be safely used in our patients. The anemia parameters have been shown to be closely matching the exogenous erythropoietin, the darbepoetin. And DREAM D study was a study where they wanted to look at how this desidustat is useful in patients who are on dialysis. And again, we are able to see that there is the time to achieve the target hemoglobin seems to be even better than exogenous erythropoietin, and the percentage of hemoglobin responders were even better than the exogenous erythropoietin. Again, you are able to see a reduction in the hepcidin levels, and the serious adverse events were not very really serious, and they are very well managed. So the dose that they have given is 100 to 150 milligrams 3 times a week. So these are very good studies which gave us a confidence that the drug can be safely used in place of erythropoietin. In fact, I would like to tell you that the first patient whom I had used this molecule, desidustat, was a patient who was referred to me by another nephrologist, saying that this patient has probably a very resistant type of anemia. We have used tons and tons of erythropoietin, and also we have given even blood transfusions, but his hemoglobin level stands at 5 grams. So these are the patient whom I had encountered some 2 years ago when this molecule had come in, and I thought that it is likely to be due to the pure red cell aplasia, which is a very rare complication of exogenous erythropoietin. So we didn't have the measurements available because these anti-erythropoietin antibodies were measurements are not freely available. So I thought, why not I use this orally available drug for this patient? And I was pleasantly surprised to find that within 4 weeks, his hemoglobin had risen to 9 grams, and we never required neither erythropoietin or blood transfusion. So my confidence levels were up, and then we had used this molecule for many of our patients. So the level of desidustat in increasing the hemoglobin levels was comparable to epoetin alpha, and the serum ferritin and transferrin levels were good. So the adverse events, nothing to talk about. So we did not encounter very troublesome or worrisome side effects. There was some studies where they wanted to check across whether these different molecules like daprodustat, vadadustat, and the desidustat, which has given better effectiveness to reduce the hepcidin. They found that hepcidin levels came down much better with daprodustat. This is again published. So how are we going to use this in our day-to-day management? So you need to have patients whose ferritin levels should be up more than 200, and transferrin saturation levels should at least be more than 20%, and of course normal vitamin B12 and folate levels. So I don't think you need to check the folate levels and vitamin B12 levels in every patient of yours. It is enough if you do a complete hemogram and you find that these patients are not macrocytic anemia is not there, then you can give them always folate and vitamin B12 and start them. So whom to give? So this is, I already shared with you my experience. So hyporesponsiveness of exogenous erythropoietin, and inflammation. Patients who are inflamed due to some occult infection like tuberculosis or sepsis, these patients also do well when you start them on this. And rural areas where limited access to cold chain maintenance, again, this tablet can be very useful. So before we start them, we need to know whom we should not use. So pregnant women, we don't have data. Breastfeeding women, pediatric population, patients who have proliferative diabetic retinopathy, because I told you when we looked at the basic signs that there could be increase in the vessel formation. So vascularization in the cells in the tissues can increase. So proliferative diabetic retinopathy, you have got to be careful. And patients with history of thrombosis and people who have malignancy, active malignancy. So, and what is the dose? The starting dose is 100 milligrams thrice a week. What I use is that 100 milligrams twice a week. The important the guideline that you have to give to your patients is that there should not be any food consumption 1 hour before and 2 hours after oxemia. Just like how we tell them to take rifampicin in empty stomach. In the same way, we need to give this drug because food seems to interfere with the bioavailability of this drug. So consume oxemia after dialysis, and the patients who are already erythropoietin agent, carbopoietin, we have the dose frequency thrice in a week, and consumption, no food consumption 1 hour before and 2 hours after oxemia. So this is again an important counseling that you need to give to your patients. If the hemoglobin levels go beyond, say, 12 grams, so reduce the dose to, say, 50 milligrams and then titrate down. And if you see that there is not much elevation of hemoglobin above 10 grams, you may increase the dose to, say, 150 milligrams. So very rarely that we have used very high doses of 200 3 times a week. We were very comfortable with the use of 100, maximum 150 milligrams 3 times a day. And the clinical benefits are that it increases the endogenous erythropoietin production in physiological range. So this is in sharp contrast when you use erythropoietin exogenously. Supposing the patient tells you that the hemoglobin levels are not going up, then our reaction is to increase the erythropoietin dose to 10,000 units 3 times a day, 3 times a week, etc. So this is going to land them in trouble because of the problems of cardiovascular events. So this is where these agents, these newer orally available agents, do not increase the hematocrit to a large number. So it won't go to 18, 19, etc. The risk of hypertension is not also there, and avoidance of high endogenous erythropoietin levels are there. These are the potential concerns. As I already told you, the malignancy, retinopathy, hyperkalemia. So this is some side effect that you need to understand, because hyperkalemia I have seen in a few patients, and only when I reduced the dose, the potassium levels came down. The second aspect is that the thrombotic events, especially on patients who are on the permacat. So I have seen that these patients who are on desidustat, there is slightly increased risk of thrombotic events in them. So these are the two things that I have seen in my practice. So this is a longitudinal study of desidustat on anemia and CKD5, which was done in my unit. We wanted to see what is the effect of desidustat, and so we have started, and we have used it in mainly on stage 4 and 5 patients, and also on maintenance dialysis patients. So we see that out of 210 patients, the patients on 169 patients were on desidustat, and the number of patients who were included in the study were 139. And the males were predominant, 75%. The median age was 54 years. The diagnosis was CKD stage 5. And then the patients who were started on 100 milligrams weekly twice was 75%. So we predominantly started them on weekly twice only. And the total number of patients with an improved hemoglobin was within 3 months was 75%. So this is a good was these patients quickly rise, and a small number were resistant despite optimal doses. And the iron status, the number of patients who had the mean serum iron and the ferritin and the saturation were all good. These patients had a good iron stores. So the mean hemoglobin rise was good, and very low number of patients, around 3% of the study group had some adverse effects which are not very serious. So it can be used to treat anemia in CKD patients, but we need more studies. And in fact, a few studies which have been published in the New England Journal on the other molecules, the other molecules of HIF have shown that there were some doubts about the cardiovascular events in these patients, so much so that there are some agents which are prevented from routine use by the FDA. So there are some worries that there could be difference in the molecules in patients who are being treated. So desidustat, I'm sure, has not undergone rigorous study that like the other molecules, but in small scale studies which have been undertaken in India, it has been shown to be very effective, and so we have been using it. So I think I will stop here, and I'll be very happy to field questions from the audience. Thank you.
Thanks, Sampath, for this kind of very lucid, at the same time very pragmatic way of looking at this. And I think for those of you in the audience, desidustat is very unique in the sense that it's a drug that we are able to use in India as something that even the rest of the world does not really know. We have to learn our own lesson. Fully a leader in this space. Any questions that the audience have, you can put it in the chat box, then I can read it, Dr. Sampath.
Sir, there was a question from Ms. Tejas. What's the difference between erythropoietin and darbepoetin given to CKD patients?
Yeah, I already told you. See, there is a lot of molecular tinkering happening on the erythropoietin molecule, so that the erythropoietin half-life can increase. So the darbepoetin has a longer half-life than original synthetic erythropoietin, so that it can be given even once in 2 weeks, once in 2 times in a month you can use it, and in that way the half-life of the molecule can increase. That is the only advantage of darbepoetin over the original erythropoietin EPO alpha.
Somebody has a question, Sampath, saying, can we use desidustat in ADPKD patients? I guess Dr. Sankar.
Yeah, see, we know that ADPKD patients have an increased risk of thrombosis. and their hemoglobin levels, if you see, there is also the cyst walls can increase the interstitial cells of the cyst walls also can generate erythropoietin. So we don't have data on desidustat in autosomal dominant polycystic kidney disease. I would advise caution unless you have patients who have clearly anemic and they require this, and the erythropoietin, exogenous erythropoietin has not been found to be useful. I wouldn't use it.
Sampath, I think Dr. Nithijan wanted to ask a question. Madam, you can go ahead.
Yes, madam.
You use the drug in CKD5, you mean dialysis patients?
Yes, dialysis and non-dialysis patients also, madam.
Dialysis patient, you use IVI?
Same dose.
IVI?
Madam, I am not able to hear you.
Did you use IVI?
Yeah, definitely, madam, because these patients also require IV iron. But after some time, we find that the iron, regular use of IV iron can be reduced. Initially we use for first 1 or 2 months. After that, we see that the iron usage comes down drastically.
Sampath, if I may ask, like,
Yeah.
for people clinically, suppose you start somebody on desidustat, like,
Yeah.
you say you're a non-responder.
Yeah.
When do you kind of take that call in terms of time? You start something. When do you clinically decide?
See, what I feel, many of these non-responders have not been given correct instructions to take the tablets.
Okay.
See, the bioavailability is a big problem in the desidustat. So I tell them that you have to take it on empty stomach, and then many of them respond well. So that is the missing link in many of our patients.
Got it. Okay, I think
Yes.
Well, has the pricing changed much? It's been around about the same, right? Since it came in.
Yes.
It's not price point has been changed. And are there any other larger trials that we are looking at?
No, I don't think, but in the ASN, we are going to have some discussion on this molecule. There is a separate session for desidustat.
Oh, interesting.
Possibly international data will be pulled in.
Oh, great. I think that's one.
Yeah.
Anybody else has any questions? I can't see anything on the chat box. Somebody has a question about ferritin on the higher side of 1,500.
Yeah.
PIBC is 169 and hemoglobin is 12.1. Although injection iron is stopped, it seems like.
No, the ferritin is an acute phase reactant, and so many times if somebody has an infection which is occult or inflammation due to uremic toxins, these ferritin levels can go up. We have seen ferritin levels go up even in COVID. So that is not it's a non-specific reactant.
Yeah. So yeah, I think I guess you don't have to react to it. Let it settle on its own. And sometimes the inflammatory markers, inflammatory cause is not even identifiable.
Yes.
Does anybody else nobody else has any question? I guess, we are pretty much.
Suresh, are you using in this?
Pardon, ma'am?
What about
But can you hear what madam is
saying? Yeah, I don't know. I am not able to hear.
Madam,
no, are you using this regularly?
Oh, I have used in non-dialysis patients, madam. Yeah, not in dialysis. But in non-dialysis, what Sampath mentioned, they have impressive response. And I think particularly the iron usage is best. But I think what I should confess is I have not emphasized the bioavailability enough.
Some of the patients are not use the what could be the reason? I don't know. Can you hear somewhere?
No, madam, I am not able to hear you.
Able to improve the didn't improve. So we give oral iron to that. What could be the reason?
Madam, only part of the question is I am able to hear.
I heard oral iron.
They are not able to improve their hemoglobin. Spike up along with oral iron and urine. What could be the reason?
I don't know, Sampath. I'm wondering whether she's asking whether you can use oral iron
Ah,
along with.
They are not improving.
They're not improved. Okay, they're not improving with their shift, but that oral iron supplement.
when they don't improve on decidustat, you mean oral iron, can it be given, madam?
No, we are giving also. In
Okay.
spite of that, not improving.
So you find that they improve?
No, they don't.
Okay.
What could be the reason?
Wait for ASM.
No, I feel that the bioavailability could be a problem, madam. Maybe absorption of this molecule requires very certain strict parameters like empty gastrointestinal tract. Even small amounts of food seems to retard the absorption. So if you can tell them that to strictly take them on empty stomach, possibly you may find a response. This I have found.
You have not seen any resistance?
Resistance we have not seen.
Are there any abstracts on decidustat in ASM? That you know? I think the book was just
I don't know.
I don't know. We'll have to see whether they.
Yeah.
I guess if there are no further questions, I'm just seeing whether there's anything in the chat box.
There are few questions in the chat box, doctor.
No, I read about Tejas Bharati's. I read the one on ferritin, decidustat and ADPKD patients, and I'm looking at after that difference between erythropoietin and this thing. I'm wondering whether anything else after that. I don't see anything. I think, yeah, just to stay on time and not to drag Sampath beyond the time that we promised. I think, Sampath, thank you very much for this audience. And, I'm sure we'll learn more about decidustat in the future. And it's truly a boon for our patients. Thank you, Sampath. And
thank you. Thank you. It's a pleasure.
Thank you. Excellent talk.
Thank you, madam. Thank you.
Thank you, doctor, for conducting this webinar smoothly. Thank you so much.
Thank you.
Thank you so much, doctor.
Thank you.